Hey guys, I'm going to go over some general information from test 4 to kind of help you guys with the final exam and kind of give you a little bit of information about what's going to be on the final exam. So first off, let me get this working. Some test taking tips. Select all that applies. I know are very hard for a lot of you guys. So we're going to talk about that for a second as soon as I get this back up. So I know Ms. Amick has talked to you a lot about taking select all that apply questions. Make sure you look at each option individually. Read each one, consider it, make it a true or false statement, and pick which ones are true. Unless it's asking you what not to do. And remember to pay attention to your questions. See what the question is actually asking you. Priority, I think, is what got you, most of you, on test 4. I did give back some alternate answers for about 7 questions off of test 4. And most of those were simply priority questions. Remember, we talked about the ABCs, DEF. So what comes first? Airway, breathing, circulation. The S is safety. Then comes discomfort, which is going to be your pain, education, and then your feelings are going to be the last. So when we're looking at which is the priority, ineffective tissue perfusion versus impaired physical mobility, circulation is going to be a little bit more important. If we're talking about pain versus, again, tissue perfusion, perfusion is going to come first. As far as education and pain, we want to get them medicated for pain or discomfort before we start in on any education. And remember, safety comes before pain. So we want to make sure that safety comes in before you're trying to medicate them for pain. You want to get them in a safe, and that also includes preventing infection environment. Thinking about the nursing process, remember, if you have enough information in the question to determine what's going on with your patient, then go on into an intervention or something else. You don't have to continue to assess. Add PI, assess, diagnose, plan, intervene, and evaluate. Again, make sure you're reading the question and seeing what the question is actually asking you. Take out any distractors that are bothering you. And a lot of you really want to overthink the question and add in stuff that's not there, and that's not going to help you. So when do you actually call the provider? If there is an immediate issue that should be addressed first by the nurse, then don't just call the doctor. They're going to ask you if you did all of these things first. If there is there an intervention that can be performed by the nurse that can improve the outcomes before calling the provider? If not, then it's okay to call the provider. So make sure you're doing everything you can do, assessing everything you can assess before you're actually calling the doctor. So remember your priorities. If you get it down to 2 answers, remember ABCs, DEF, and your nursing process. Delegation was another one that got you guys too. For RN, can delegate to an LPN or a unlicensed assistive personnel. And you can only delegate tasks that do not require the RN's care. So different things that you can delegate to the unlicensed, things like your AELs. They can feed, they can toilet bathe and ambulate. Of course, none of them can do assessments. LPNs can do some meds. They cannot do education. Some LPNs can do IVs and anything that fosters the RN to the patient relationship, like their plan of care. So remember, for LPNs, we cannot delegate the acronym TAPE, Teaching, Assessment, Planning, and Evaluating. And a lot of that sounds like our nursing process, right? So remember that when we're trying to figure out who to delegate what to. All right, so these are the things we're going to focus on for mobility. Traction. Remember the two different types of traction. Skin traction goes on the skin, so there's no pins involved. Skeletal traction has the pins, so you want to make sure that you are very meticulously cleaning those pins, giving good pin care. We pay attention to the weights, and we pay attention to the actual pulley system, the traction system, to make sure there's no defects or anything altering the action of the traction. Ensuring proper body alignment and making sure you keep them up, pulled up in the bed so that those weights aren't dipping down to the floor. Fractures, we're focused on hip fractures, but remember, if you have a fracture, we really need to assess your pulses, the temperature, the color, all of those things to make sure that we have good circulation going on. Some things you may hear from the patient, you know, distal to the fracture, they may be feeling some numbness or tingling. Of course, with fractures, you can see there's going to be bruising, and there may be some deformity too. And complications from fractures, know these complications, signs and symptoms to look for, and how to treat them. So fat embolism, they're going to get tachypneic, they're going to have some dyspnea, they're going to be kind of anxious, a restlessness. Classic sign is going to be the petechia, kind of around the neck and chest area. And with compartment syndrome, we talked about that with Cass, but you can get compartment syndrome anywhere there in the body, basically. You're going to have pain that does not go away with any medications because it's pushing on those nerves. So that's a different type of pain. So with hip precautions, know these, you know, we don't want that more than 90-degree flexion. We're going to keep those those legs straight. We don't want them rolling outward, no crossing the legs, and no moving that leg out. So we kind of want to keep that abduction pillow on there, pillow in between. Be careful when you're sitting them up or getting them up, and remember education with that. Amputation, little acronym here. Again, we're going to monitor for circulation, we're watching for infections. We're going to position that stump onto the pillow. And don't forget that we need to lie them prone. So starting 24 hours, we need to make sure that they are lying prone for those lower extremity amputations. Implement shrinkage interventions. That's going to be your figure 8 ACE bandage on the end of that stump. Pain management. Again, avoiding that prolonged sitting is preventing those contractures in the hip. And again, that's why we're doing the prone positioning, and encourage and support during that grieving process. Basically, we want to prevent infection, decrease swelling, keep an eye on the incisions, making sure we're doing good wound care on that, pain management, psychological support, and rehab. So we want to get them back to a new normal way of living. Again, focus on this slide in your PowerPoint. I won't go back over that. Gout, again, there's a few slides in there about gout, but no, the tophi, the little nodules that they get under the skin, know what to educate them on diet-wise, And what is gout? It's the elevation of uric acid in the body. So we're going to see an elevated uric acid in our labs. Medications, acutely, we're going to do NSAIDs and steroids, and we're going to do the colchicine. For long-term effect, we're going to do the allopurinol. Back to fat embolism and compartment syndrome. Typically with fat embolism for treatment, there's not really a specific treatment. We're treating the symptoms. Usually we're going to do steroids, start on IV fluids. So they'll need an IV for that. And they're probably going to end up in ICU. So basically with a large bone fracture, some of the marrow from inside the bone can actually get into the blood system, and that's what actually can travel through and end up just like a blood clot in the lungs or in the heart. Compartment syndrome, removing the constriction. So if it's a cast, they want to relieve that pressure by cutting the cast. Or if it is just skin, they're going to do that fasciotomy where they actually cut open the skin to give that the inside time to decrease that swelling. All right, so we're going to go over the protection stuff. Remember, the biopsy is the gold standard. Know your ABCDEs for melanoma. And treatment for that is usually excision. We don't typically do chemotherapy with that unless it has migrated somewhere else, unless they have metastasis elsewhere in the body. Remember, with chemo and radiation, you can have a lot of these common complications. So how we're going to treat them? So malnutrition. What's causing them to be malnourished? Is it sores in the mouth? Is it a change in taste? So how we're going to fix that? We talked about a lot of the Ensures, all those protein drinks and things like that. Preventing infections. Mucositis. Remember, we're meticulous mouth care, brushing our teeth between meals, making sure we're reporting any, damage or soreness in the mouth first thing. Anemia, we talked about that. Sometimes we have to do medications for that, and just supporting their body through that anemia. Thrombocytopenia, we may need platelets. With anemia, we may need blood transfusion. And then alopecia, how are you going to care for those patients? So know the complications and what we're going to do to prevent them and what we're going to do to treat them. Know your labs. As y'all saw in the last test, we give you a set of labs along with a little patient scenario, and you have to figure out, answering the question. Like we talked about, platelets. That's going to be your bleeding. So if your platelets are low, we're going to do bleeding precautions. Just because your hemoglobin and hematocrit are low does not put you at risk for bleeding. We talked about that extensively. Remember neutropenia. We'll get to that in just a second. There was something else I was thinking. Oh, and if they're all normal, we throw a lot of abnormals on the test for you guys, but you got to know how to treat the normal too, because you're going to see that. So if you walk in and all your labs are normal, you're going to treat them just like any other day, even if they're getting treatment. So usually at the beginning of your treatment, you don't see much of a change in your labs, and the more that they go through treatment, you're going to see that drop in those labs. So if their labs are telling you that their white count is normal, their body can fight off that infection. So you just want to give them normal infection control education. Neutropenic precautions. Remember hand washing, a private room. They don't need to be isolated, but You know, they want to protect themselves from sick people, no fresh plants or fruits or veggies. So know this slide. Remember 100.4, 100.4. If they are that or above, they're considering that a fever, so they need to do something. Typically, we're going to do blood cultures, urine cultures, chest x-ray, all before you do any antibiotics. Start on the broad spectrum, and then as you get these cultures back, then you're going to change to whatever's going to kill that bacteria or infection that's going on. Thrombocytopenia, that's going to be a platelet count of less than 100,000. Back to neutropenia, not neutropenia, but anemia. If your hemoglobin is less than 7, you're going to think about transfusing. If your platelets are less than 20,000, you're going to think about transfusing. But if their platelets are less than 100,000, they're thrombocytopenic, and we need to do some type of bleeding precautions. All right, thinking about the liver with hepatitis. What does the liver do? It detoxifies, helps with digestion and metabolism. It helps break down things and convert to energy. It produces your clotting factors, and it stores your vitamins and minerals. So know what your liver does so that when it fails, we know what kind of things to expect. So if our liver's failing, we're going to have issues with clotting. We're going to have issues getting this stuff out of our body, this bad stuff out of our body. We're going to have a hard time metabolizing these things and giving us energy. And we're going to be vitamin and mineral deficient. So the 3 stages of hepatitis. Icteric is pretty much the jaundice stage. So you got before jaundice and after jaundice. So the early stages, like we talked about, it's going to be those flu-like symptoms. They may have a low-grade fever and just feel just kind of crummy. With that icteric stage is when they're going to start noticing that jaundice, which is going to be in the skin and the eyes, that dark urine. They may have some itching starting. That's the increase in that bilirubin. You're going to see some elevated LFTs. And if their ammonia's elevated, you may notice some confusion, and you may have to treat with lactulose. As they get through this, they come into post-icteric, and that's the recovery phase. You're going to see those labs kind of return into normal. Their energy's coming back, they're going to feel better. So basically, we're just supporting them through this. Giving medications for increased ammonia levels, stuff for nausea, stuff for pain, anything for the itching. They're going to give them some antivirals just to kind of support them through until their body starts recouping from that liver damage. If not, you could potentially progress to liver failure or cirrhosis, and they may need a liver transplant. Herpes zoster, I think pretty much everybody's got that down. That's pretty much shingles. How are we going to treat it? How do you know it's shingles and that kind of thing? For liver, know these labs. So back to reviewing nutrition, peptic ulcer disease. No, gastric ulcer versus duodenal ulcers. I couldn't come up with the word. Some complications from that. Know how to recognize the complications and what to do. Same with GERD. What kind of things cause GERD? What kind of signs and symptoms are you going to see? Gallbladder disease, who's at risk? What kind of signs and symptoms? Big thing with them is surgical teaching and obesity for patient education. decreasing obesity, dumping syndrome, post-surgery, those kind of things. Remember, we don't do NG tubes with bariatric surgery patients because we don't want to mess up those surgeries. So if it has a question about an NG tube, you can throw that answer out because we know we're not going to put in an NG tube. Upper GI bleed. So it's in the upper. You may notice the dark tarry stools. If it's coming out, it's going to be that coffee ground looking emesis. Know the difference again between Crohn's and UC. I did end up giving credit back for that one with the picture. Be more mindful of that picture. So there may be a picture coming up with that one. What kind of diet? Be able to recognize a diet, educate on diet. Intestinal obstructions, what kind of signs and symptoms are you going to see? Same with peritonitis, what can cause those things? Hernias, and we're looking at complications and care after the repair. And then colonoscopies, getting them ready for colonoscopy. Sensory, post-surgical education for cataracts. You know, you don't want to do anything that's going to cause pressure on those eyes. Meniere's disease, education on that, particularly diet. Education on retinal detachment, what to do with those. Vertigo, no treatment and interventions for that. You know, you want like a pretty much no stimulation, a calm, quiet environment, just kind of no stimulation to increase that vertigo. And then no angle closure glaucoma. Go refresh your skills. Drains with the JP drains. Remember, JP and Hemovacs, they work from suction. So the bulbs for the JP drain has to be compressed and closed for it to do its job. Same with the Hemovac. It's more of a round, so you're going to squeeze it down, close it, and it's going to slowly deflate and pull out any drainage with that. Review wound vac care. Some of you missed those questions about the question about wound vacs. We don't change those dressings every day, typically every other day. And if you do not have a good seal on them, they're not going to get a good suction, and your wound vac machine is not going to work appropriately. Review your injections. Methods for doing IM, sub-Q, and intradermal injections. Know your sizes and gauges of needles in your syringes. Caring for new ostomies. What should the ostomy site look like? And again, suture, staple removal, doing those. Remember, don't forget your making sure that you're supporting that incision. And if you are going to remove those and it looks like the incision is not approximated, you may need to call and defer removing those sutures or staples. If you have any questions, feel free to email me at coatesm@midlandstech.edu for any of the nutrition, elimination, mobility, protection, and sensory questions. Test will be on Friday, the 10th of December. That will be on campus. Remember, the 6th is the last day of class. So if you're going to withdraw, make sure you withdraw before that date, or the grade that you have earned is what will stand. So if you are not got a good grade and you do not withdraw, you will get that grade. Again, please reach out, coatesm@midlandstech.edu, and let me know if you have any questions. So I hope this helps a little bit, along with the final exam study guide that was posted earlier in the semester.